Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Hamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. Mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. Good morning. This is Dan Gatis, and thank you for tuning in, sharing the morning with us, being early birds like us, and being a part of Kingston Community Radio. Monday, July 19th, and 66 degrees starting out right now with a little bit of drizzle, cloudy skies and drizzle early, followed by partial clearing, a stray shower or thunderstorm possible today, a high of 81. Tonight, partly cloudy, a low of 62. Tuesday, mainly sunny, a high of 88, and Tuesday night, partly cloudy, a stray roving shower or thunderstorm possible, a low of 65. And Wednesday, mostly cloudy with a 40% chance of thunderstorms, a high of 81 for Wednesday. Wednesday night, mostly clear skies, a low of 51. We'll be right back.
Starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
There's a threat targeting America. One that's growing fast, but may still be hard to see. Lyme disease. Spread by tiny ticks, often smaller than the head of a pin. This dangerous disease is now more widespread than West Nile, tuberculosis, and HIV/AIDS combined. And if left untreated, it can lead to arthritis, facial paralysis, and even memory and concentration problems, often called brain fog. As the threat of Lyme disease grows to more than 300,000 projected cases each year, it's time for us to target Lyme disease. That means checking for ticks when you've been outside, even in your own backyard. It means seeing a doctor if you experience the symptoms of Lyme disease, which can include joint pain, flu-like symptoms, fever, fatigue, or sometimes a bullseye-shaped rash. Set your sights on stopping Lyme. Learn how you can target Lyme disease at targetlyme.org. Brought to you by the Stephen and Alexandra Cohen Foundation and this station.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you and support KCR.
And thank you for supporting KCR, and thank you for listening right now. You're listening to KCR, Kingston Community Radio, WGHQ AM 920, 92.5 FM, and streaming online at mykcr.org. KCR is talk radio and a call-in show, so your number to call in is 331-9255. Every time, anytime, 7 to 9 a.m., weekly, on every weekday. And please visit our Facebook page at facebook.com, groups KCR920. Now let's get to the on-air studio with Dr. Eric Stamberg and Robin Baker. Welcome.
All right, good morning. Welcome, everybody.
Good morning.
All right, we are here today to do Medical Mondays from 7 a.m. till 9 a.m., Please feel free to call with any medical questions or comments. What is the number again, Dan?
331-9255. How many times do I say that? 331-9255.
How many times do I ask you?
Unless I read it.
How many times do I ask you to say it?
Yeah.
331-9255. And let's see, it's a rainy summer.
Very.
Yeah. And but it looks like it's going to be a little steamy over the next few days, right? Around 90?
Let's see, 81 today, and Wednesday is 81. Pretty much like that.
All right.
For the first beginning of the week, down to 51 on Wednesday night. That's kind of neat.
All right.
Yeah.
Well, we got a lot going on.
Yes.
So the first thing, I always like to revisit topics because they kind of come up, and I think people, it's okay to discuss things again. But The last thing I heard before before we started was a commercial about Lyme disease. Very dramatic. It's more common than tuberculosis.
How common is tuberculosis?
In this country, not very common. I can give you numbers worldwide, but it's not saying much. But anyway, they are making some valid points, but the dramatic tone of it is a little, I don't know, a little dramatic.
Yeah.
That was pre-COVID, so, it was a big thing.
Those were the days when that's all we worried about.
Right.
Whenever I diagnose Lyme disease, and it's frequently, I always tell the person the great majority of cases of Lyme are diagnosed rather easily and efficiently, and are likewise treated rather easily and efficiently. So trying to set the stage from the get-go that the patient's kind of going to be okay, the great, great, great majority. So, and that's true. That's not a misstatement. I'm not kind of sugarcoating, trying to play mind games with the patient. I'm trying to just reassure the patient, which, by the way, is a big part of what we do.
Right.
So the Lyme disease is caused by a bacteria called Bordetella burgdorferi, and it's transmitted by a certain species of tick called Scapularis ioxides. I think I'm saying that right. It's also called the deer tick because it's very dear to our heart. No, because it's kind of likes to hang out on deer, and it also likes to hang out on mice. And it's an interesting subject. I mean, when you were growing up in the 50s, Robin.
Oh, come on.
Okay, and I meant the 60s. How about the 70s?
Yeah.
When you're growing up in the 70s, do you remember getting bit by ticks
No.
when you played outside? I don't either, to be honest with you. The first time I ever had a tick bite, I remember when I was in college, I was in Connecticut for a couple months, and I remember having one then. That was the mid-'80s. By the way, that's where the name of the disease comes from, Lyme, Connecticut. It's not Lyme's disease. It's Lyme disease. So a lot of people who kind of think about this, what's going on with ticks? Where are they all coming from? Some of it has to do with an increase in deer population and also kind of development. The fact that maybe these ticks were kind of dispersed in the woods, but now they're all a little more concentrated. I mean, it's an interesting subject, but I honestly don't remember being bit by a tick when I was a kid. And believe me, you played outside a lot. I played outside a lot. Yeah. So it's interesting. And it's very important for people to kind of keep in perspective what to do if you get a tick bite. It's not an urgency or an emergency. There was one study at this point that came out about 20 years ago that supported giving a couple doses of antibiotic if you had a tick bite. The study had a lot of caveats attached to it. It had to do, you had to really clearly identify that it was a deer tick. That's not really easy to do. For one, we're not entomologists. We're not, trained to identify a deer tick. The other one is generally when the tick is removed, it gets kind of a little mutilated in the process. So even your attempts after it's removed to put it on a tissue and, I guess people use their phones now to magnify it. It's still hard to do. So anyway, so the study said it had to be identified as a deer tick. It had to be attached for about 36 hours. Your typical tick likes to hang out on your body for as much as 72 hours, 3 days. And those are the basic criteria. So, by the way, as a tick is attached, it gets more engorged, right? You see these ticks when they're kind of engorged?
Yeah.
Yeah, they're really
It's yucky.
science fiction creatures.
Yeah.
They get even harder to identify once they're engorged. So anyway, this study supported potentially giving a couple doses of antibiotic after a tick bite, and the CDC also endorses that. But the study was really not replicated to my review. It's kind of like, what's the big deal? The regimen is simple. It's 2 doses of doxycycline. That's it. 2 doses. You take it at the same time. And you want to do it within 36 hours of the tick bite. So
Or else it won't have a benefit.
Right. And so that's why it's not an emergency. It's not a reason to run to the ER. Look, if it's Sunday afternoon and you feel like going to urgent care for it, that's okay, I guess. but just kind of keep it in perspective, you know. It's an okay thing to do, the doxycycline. But I just want to emphasize that that's what the treatment for a tick bite is different than the treatment for Lyme disease, and you don't really get a prolonged course of antibiotic just by taking a couple doses of just by having a tick bite. You really, the regimen is really just 2 doses. All right. Anyway, so why are we bringing ticks up?
It's tick time?
It's tick time. So the ticks are out, we're out, and you can generally develop symptoms of Lyme disease anywhere from around 3 days to 3 weeks after being bit. And the symptoms can be complicated. Lyme is sometimes classified into early, mid, and late stages. So generally when people are this time of year, it's the early stage. Even the early stage is divided into primary and systemic or disseminated Lyme disease. So primary is really just the rash. Someone comes in and they say, I was taking off my shirt, and I saw myself in the mirror, and I got this, look at this. It's a rather large kind of welt. And it typically can have a bullseye appearance, although not always. Sometimes you have to stand across the room and kind of to appreciate the bullseye pattern a little bit. But very few things kind of look like that in medicine. And a key part of the story is Lyme ticks have a little anesthetic in their saliva. I can't even believe we're talking about tick saliva. But they have a little anesthetic that makes you not feel them. So generally when you get bit by other things, you feel it. A lot of people always say it's a spider bite. Spider bites kind of hurt. They're biting you. There are stories and reports that even though they're biting you, while you're sleeping, maybe you won't wake up or whatever. So that's possible to get a spider bite and not know you got bit. But generally, if you have a big something that seems to be a bite and you don't remember being bit, it is probably a tick bite. So that's just one thing to remember. Generally, when someone has this rash, there's very few things in medicine that look like this. So you don't necessarily need to do testing. And the testing, actually, because it's early, might be negative anyway. So you make a clinical diagnosis of Lyme disease, early localized Lyme disease. For a long time, we said the treatment was 3 weeks, doxycycline. That was mostly because the experts couldn't agree on whether it should be 14 days or 28 days, so they kind of compromised on 21 days. But really, recent evidence suggests that early localized Lyme disease just needs 10 days of antibiotic. The antibiotic is almost always doxycycline, which is used a lot these days. The problem with doxycycline, there's a big one this time of year, is it can cause a rather significant sun reaction, what's called phototoxicity. So, people are outside a lot. People work, outside. So if there's a reason why doxycycline should not be prescribed, we would use amoxicillin. So these are basic, non-fancy antibiotics. So the cost of treating the disease, at least in its early stages, is low.
Are there any other symptoms accompanying the rash?
Well, if it's early localized, the answer is no. You'll feel fine. You'll just, you'll just say, hey, what's this? By the way, the most common site of the tick bite is probably behind your knee for a couple basic reasons. Ticks are in the ground, so if they're going to attach to you, they'll kind of crawl up your leg. And generally, when's the last time you looked behind your knee? So it's an area where ticks can kind of hang out long enough and not get noticed and maybe give you Lyme. I remember years ago when I first started practicing, being at the community pool in New Paltz, talking to one of my patients, and I don't know, he must have turned around or whatever, and I saw the rash. I said, "What? You got a Lyme right there." And he felt fine. And another common sites to get the initial bite are in between the toes. Remember, a lot of people wearing sandals, open-toed shoes this time of year. In the groin, it's not the most glamorous place to get Lyme disease, but ticks can kind of crawl up your leg into the shorts. Women, sometimes under the breasts, in the armpits, behind the ears. interesting. Kids can get Lyme. What do kids do? They kind of roll around and play, so they're more likely to get the tick bites on other parts of their body, whereas adults probably, But anything's possible. People with pets, the ticks can kind of come in if your pets go outdoors, or even everyone doesn't take the dog for a walk. So it is important to treat your pets for their sake as well as your sake. Dogs will get Lyme disease. Cats actually don't really get Lyme disease, and this is complicated. Why one species gets the disease and other doesn't. I don't know the answer to that, but they can certainly transmit and bring it into your house. So it's important to get those treated. Dr. Bannister, remember our guest from pre-COVID days.
Mm-hmm.
Pre-COVID. So
it's important to do a tick check. Right? Preventatively. Yes. Generally, prevention's always the best treatment. So generally, you want to avoid the tick bites, but at the same time, we want people to be outdoors and active. A couple basic things. If you go hiking, to really try to keep your arms and legs kind of covered. I know that's hard, because it's hot. Wear light clothing where you can kind of easily spot a tick on the clothing. It's controversial because some people don't like to use DEET, which is a kind of a chemical spray that will keep the ticks away. There are a lot of alternative or natural products that, whether or not they work or not, I'll leave to the makers of the product. But DEET has been shown to be effective. And yes, after potential exposure, a nice tick check. Kids probably get the tick check because, I think maybe, at the end of a hot, sweaty summer night, they come in for a bath and the parent is bathing them and notices these things. Sees you everywhere. Yeah. So there's these new sites. If you go online, you can look them up where you can send away your tick and have it analyzed.
Yes.
Seeing that a lot.
Yeah, and that's not really new, but where did you see that? Just kind of like...
the patients are doing it.
I don't find that helpful for a couple of reasons. One is just because the tick may be a deer tick doesn't mean that tick has Lyme in it. Although they might be testing for that, okay?
Yeah.
Okay, fine. So even if the tick has Lyme in it, that still doesn't mean you have Lyme. And so to me, my patient is you, not the tick. And plus it takes time. It probably takes about 2 weeks. I don't know what the turnaround is. There's probably an expense to it. So I don't think that's necessary. I will recommend against having that done. For reasons I just said. I think that if you have a tick bite, and you're concerned, and I don't blame you for being concerned, but you should consult your healthcare provider. We tend to, in the Kingston office, prescribe the tick bite prophylaxis. Rather, I think that's much more valuable intervention for you than having the tick analyzed. Sometimes patients bring in the tick and they say, "Here, can you have this tick tested?" And I say, "We really don't accept the tick's insurance in this office." So,
well, I just Googled it quick, and the first thing that popped up is it's called Tick Check. And it's a Pennsylvania tick testing laboratory.
Tick testing, yes.
And it says, interestingly enough, that over 46% of ticks carry Lyme or another tick-borne disease. So that means that 54% of ticks don't carry that.
Round it to 50. Half of the ticks are carrying. Yeah, I'm not sure where those numbers are coming, but that's a lot. To me, that argues against the testing because if you have 50% chance that the tick is infected with something, it just underscores that you need the evaluation and not the tick.
Right. So they say within 99.9% accuracy, and you can send away for a tick test, or you can send the tick directly to their lab.
Do they say what they test for?
They get the results within 24 to 48 hours. No. Doesn't say that.
There's also that popular channel where, TikTok, where people post videos of the ticks dancing and stuff like that.
That's not true.
No, that's not it? All right, anyway.
Boomer.
So
these places are out there, but
as you're saying, we reiterate more and more, how are you?
Yeah, right. You're
What are
the patient.
what are your symptoms and how are you doing? That really, the prophylaxis is the 2 doses.
Right.
And
So if a patient came in to me and said, "Hey, I got bit 2-3 weeks ago, and I sent this tick away for testing, and it came back positive," I imagine that maybe they're testing for other illnesses
yes,
too.
right.
And
Other
it came back-
tick-borne.
Yeah. So it came back positive for Lyme. My first question would be like, well, how are you feeling? What are you experiencing? And if they're having some symptoms, the threshold for working up Lyme this time of year is very, very low because it's common. And I always say if someone has like symptoms like a fever, for example, if I can't explain that fever away by something obvious, someone comes in and they have a fever and they're runny nose and they're coughing, that's not Lyme, that's a respiratory illness of some sort. But if someone comes in and they have a fever and I can't find anything else, that is, in my opinion, tick related until felt to be otherwise. So if someone is symptomatic, if they come in and they have the rash, you really don't need the testing, okay? Because that's another thing that people will say, might be told this by various urgent cares or other providers. If you got bit by a tick, get tested in a month. Or I'm not so sure that's necessary either. I would ask the same thing. What are your symptoms?
So you're saying if you're bit by a tick, a month goes by, you have no rash, you have no achiness, you have no fever, you have no signs of illness, you don't need to be tested just because you had the bite.
Right. And one more point I wanted to make is I really believe that the tick bite that gives you Lyme or another illness is probably the one that did not get noticed. For the reason we just went through the areas, behind the knee, and the hair. So generally, if you see something on your arm or your leg, it gets removed. It probably gets removed in a fairly timely fashion and not in a way to be there long enough to increase your risk of having it transmitted. So the whole idea of a tick bite in general, I don't know. I just not so sure that it's worth the attention. We do follow the guidelines issued by the CDC of tick bite prophylaxis with the doxycycline. But we don't necessarily treat more than that. I don't usually recommend testing unless you have symptoms. So what are the symptoms of Lyme? Okay, we talked about the rash, but the rash can be early localized Lyme, and that's all you could have. You could feel perfectly fine. Lyme is a bacterial infection, and it causes symptoms similar to many other infections. Fever is a biggie, achiness in your muscles or joints, headache, stiff neck, maybe swollen glands, and it can make people feel quite ill.
And the treatment?
The treatment's kind of the same. It's doxycycline, or for a reason you can't prescribe it, you use amoxicillin.
For a 21-day course?
No. 21 days is pretty much out. I mean, again, early localized is just 10. If someone has systemic symptoms, 14 days is considered okay these days. It's interesting.
So what if they don't feel better?
Well, good. You want to sometimes consider the possibility of other tick-related infections. This is a big source. That website's talking about it. Kind of what they call Lyme literate or alternative doctors will talk a lot about co-infections. The big ones that we see are two very similar entities. So you'll hear these terms almost interchangeable: anaplasmosis and ehrlichiosis. These are also bacterial infections that cause symptoms almost identical to Lyme, except no rash. And they can make someone very, very sick. And this is a little harder diagnosis to make because, the Lyme, there's testing for these organisms, but it's not quite as sensitive as Lyme testing. By the way, when someone has Lyme symptoms, in addition to testing specifically for Lyme, other blood work can be helpful. So if you do just basic blood work, which is a CBC, a complete blood count, white cells, red cells, platelets, the Lyme and also those other entities, anaplasmosis and ehrlichiosis, can actually suppress bone marrow. So one of the things you might see is a low platelet count, and you might see a low white count. So that's one clue you can get just by doing a CBC. And also on what's called a metabolic profile, what's included in this profile are some liver enzymes called AST and ALT. And those might be elevated. So routine blood work might give you some clues while you're waiting for Lyme testing to come back. That's sort of what happens in the ER setting a lot when someone presents with possible Lyme symptoms. They don't really have a rapid test. But you could do some routine blood work. All right.
Hi, Mom.
Hi, good morning to Marcia and Arthur, who are watching the show. All right. All right, so we covered symptoms of early Lyme, and we covered kind of the systemic symptoms. What makes us think maybe you're sicker? Lyme can invade the nervous system and cause a type of meningitis, for example. Well, that's a bad term, right? Meningitis, by the way, make you very, very sick. Rarely, and I'm not even sure if ever is fatal. Okay, but it needs to be diagnosed. So, and another complication of Lyme is something called Bell's palsy, and it's an interesting topic unto itself. But Bell's palsy is a paralysis of something called the facial nerve, which kind of controls the muscles on one side of your face. And it has some other things it does too. It has a little role with taste and hearing. So when your facial nerve is affected, you might have some weird sensations on your tongue, and you might have some ear pain or ear discomfort as well. It's a dramatic presentation. The person literally has kind of a droop. And you always can tell by, asking the patient to raise their eyebrows if the side that's affected also kind of droops on the eyebrows, and that makes the diagnosis of Lyme disease. Of Bell's palsy more likely. Anyway, so Lyme is a cause of Bell's palsy. I got weird spins I give patients sometimes when I diagnose Bell's palsy. First of all, especially this time of year, I run testing for Lyme, but I almost always kind of start treatment. If the testing comes back negative, I say okay, but I don't want them to wait a couple of days. Other doctors might disagree with that. But I think your prognosis, if you have Bell's palsy due to Lyme, your prognosis is better than if you have Bell's palsy by itself. That's called idiopathic. It kind of just happens. Another common cause of Bell's palsy are viruses, particularly the herpes simplex virus. If it, just like it can kind of affect the nerves around your mouth, which make it kind of erupt as cold sores, it can kind of invade the facial nerve and cause a Bell's palsy. Interesting, right?
Does it recede? Does it go away?
Yeah,
under certain circumstances,
most people will resolve from Bell's palsy. There are some people with just some chronic residual. I'm the doctor; I can kind of see it. Maybe most people can't notice it, but yeah. So the prognosis is pretty good when someone has Bell's palsy, but it doesn't mean it's easy.
Not fun.
Yeah, not fun. That's a little bit of a side, but just remember that Lyme disease is a cause of Bell's palsy. But sometimes someone has Bell's palsy and they're also still very sick, a lot of headache, a lot of fever, or if they just have persistent fever, stiff neck, and headache, a lumbar puncture is done, an LP. Same thing as a spinal tap. Those are synonyms, by the way. And you're looking for evidence of Lyme disease in the nervous system. And if that comes back positive, the treatment is something called Recefin, which is an intravenous antibiotic. At current standards, they would go by the Infectious Disease Department of Medical Associates of Hudson Valley, have something called a PICC line placed, and come in once a day for a month to get their dose or whatever. Still, I just want to emphasize the prognosis is still very good, even when someone is that sick from Lyme. So that's just something to remember. And it can affect a joint, particularly the knee. This tends to be kind of a late finding of Lyme, about 3 to 6 months after it. So we tend to see this problem in the fall or even the winter. The knee will be very swollen. Again, I same speech. When this is diagnosed as Lyme, I say to the person, you know what? It's going to get better just by treating with the antibiotics. And you don't need the Recefin for this. You could just treat with. Usually at that point we do 4 weeks of doxycycline. But that's because other cause of a swollen knee, like a torn meniscus or cartilage in your knee, that's potentially something you need surgery for. So it's it's a weird spin I sometimes put. But I got good news for you. You have Lyme disease.
So, Doc, we might have to table this till after the break, but are you cured from Lyme? I mean, there's a lot of people who say that Lyme stays in you and that it's chronic. and that you can just get it again. You can just flare up inside you.
Well, this is the controversy. It comes back to what I started by saying. The great majority of people are easily diagnosed and easily treated, and they do just fine. Are there chronic symptoms of Lyme? A lot of people will tell you no. A lot of people will tell you yes. I think sometimes I explain to patients, I said, yeah, it's kind of like, if you broke your ankle, the fracture might be healed, but you still every now and then might have some, achiness in that ankle or whatever, on a rainy day or whatever. So maybe is the answer. The idea, we're going to go to a break and we'll revisit, but the idea of brain fog, by the way, how subjective a symptom is that? All right, let's go to our break.
Thank you, Dr. Eric Stamberg, Robin Baker, and thank you for being with us here on a Medical Monday, and you're listening to KCR, Kingston Community Radio on AM 920 and 92.5 FM, and streaming online at mykcr.org. My name is Dan Gatis, and it is 7:30 a.m., and Monday, July 19th, 66 degrees now right here in Uptown Kingston, and today, cloudy skies, drizzle early, followed by partial clearing. Stray shower or thunderstorm is possible with a high of 81. Tonight, partly cloudy with a low of 62. And Tuesday, mainly sunny with a high of 88. Tuesday night, partly cloudy, a stray roving shower or thunderstorm possible, a low of 65. Wednesday, mostly cloudy with a 40% chance of thunderstorms, a high of 81 for Wednesday. And Wednesday night, mostly clear skies with a low of 51. We'll be right back.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Get ready to go with Central Hudson on an epic adventure at the Dutchess County Fair, August 24th through the 29th. Visit us at our main booth in Building C and say howdy to Zoltar the Fortune Teller, who will predict your energy future. Then pop over to Central Hudson's booth at K29 to score 10 LEDs plus a desk lamp for only $10. See you in Rhinebeck at booth C30 and K29. Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
Hi, this is Cameron Rylands from Kingston, and I support Kingston Community Radio because it's informative.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. 66 degrees on this Monday, July 19th, and a little drizzle, but a fair amount of clearing later on today. Our call-in number is 331-9255. 331-9255, and this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. Let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker. Welcome back.
All right. Thank you. Welcome to the second half hour of this morning show.
Da-da-da.
We shall be here until 9 a.m. The phone number is
331-9255. 331-9255. Put it on your refrigerator.
You're doing that on purpose.
All right, 331-9255. We should try to wrap up the Lyme disease discussion. A couple other points. Lyme can sometimes affect the heart and cause what's called AV block. Basically, the top part of your heart needs to communicate with the bottom part, so it can beat, boom, 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 boom. That's the top and the bottom. And if that connection is slow, that's called a block. And early cases of Lyme, when there were fatalities reported, were almost always due to this, because the heart would slow down and stop pumping. So anyway, that's just one complication. to consider. Again, the similar speech though. Once it's identified as Lyme disease, when you start to treat it, the condition usually improves. And because other causes of that type of block, someone would maybe need a pacemaker for. Common related tick entities. I mentioned the anaplasmosis and the ehrlichiosis, very similar symptoms that can make people very sick, particularly older people. And yes, this can cause illness so severe that can be potentially fatal, but easily treated with just 10 days of doxycycline. Finally, there's a fourth entity called babesiosis, which is a parasitic illness that is becoming more common. I don't want to get too much into the details of this symptom because it's kind of a separate subject, but the treatment's different. You use something called atovaquone, which is for malaria. Interesting, right? And you also use azithromycin. All right, we have a caller. Good morning, caller.
Good morning. I want to ask you something else. This is about spider bites. And this is with the brown spider. It's a small spider.
Good point.
The venom on it is supposed to be really bad on that. Have you heard anything about that?
Yes.
Anything you could talk about?
You know, someone very close to me recently had a spider bite that is a brown recluse spider. My daughter Sarah. She's fine. She had to go on antibiotics, but it healed up just fine. But there's really only two poisonous spiders that are indigenous to the United States. One is the black widow, and one is the brown recluse spider. The black widow does exist. It lives in the mountains, and it causes like a poison type illness, a fever, and like that. And there's an antidote to that. The brown recluse has a toxin that it can kind of inoculate your skin with, that can kind of almost eat it up. Anyway, for a long time, I heard over the years that the brown recluse really doesn't exist in New York State. But things change. Remember, we travel a lot now. You know, the idea that brown recluse can crawl into the bed of a truck that traveling from another part of the country, and now it's in New York State. So yeah, it does exist. Matter of fact, my daughter found another one in her apartment, which was dead, but she took a picture of it and showed it to me, and it really is a brown recluse spider. They're actually kind of big. And I love this other name for it. It's called a fiddleback spider because it has a pattern on the back that kind of looks like a violin. Anyway, so they exist. And so spider bites, many spiders bite. The issues are they poisonous. So there's only two that are poisonous that belong in the United States. You know, look, every now and then someone has a pet tarantula that gets out of the cage or whatever. I don't recommend those either. Sorry, PetSmart. Anyway, so yes, the brown recluse does exist.
Yeah, because I used to live in the Bronx, and the last place I lived in was in Throgs Neck, and I know of somebody there who had been bitten by the brown spider, and she didn't get treated for it. She did lose her hand from it.
So sometimes the wound gets so bad that a surgeon has to kind of clean it up. Take away this what's called necrotic tissue, and it could be bad. It could be very serious. So brown recluse, it exists. That's all. Any bite by an insect, and if spiders are arachnids, technically not insects, but generally a bite should get worse over 1, 2, 3 days and then start to recede. So if you ever have some sort of bite that's kind of getting worse beyond 3 to 4 or 5 days, then it really should be looked at. I think that's good, advice to follow.
Yeah, I know, because I know you don't hear it too often. You always, now this thing with the ticks and so many people, and getting sick from it and stuff like that, and it just seems to be more and more, that people are being affected by it, so it's important that people, do check themselves after they come in, but you don't hear much about the thing with spider bites,
right?
So
trust me, for every brown recluse spider bite, there's probably 1,000 deer tick bites. I mean, there is a much different sense of proportionality here. So thankfully the brown recluse spider is not that common, but I don't know, maybe it's becoming more common.
Yeah, I know, but this was years back because I moved up here in 1974, so up this, the sororities. But like I said, this happened quite a while ago. That this woman had actually lost her hand because of it.
So her hand actually had to be amputated?
It had to be amputated.
Oh boy,
yeah.
see, that's horrible.
Yeah.
Yeah.
That's why it's a little scary.
You seek treatment for sure.
Right. So follow those general rules. A bite should get worse 1, 2, 3 days, and then start to recede.
Uh-huh.
Any bite that's causing systemic symptoms, fever, achiness, headache, also I think you should seek care for. And then just any bite that seems to be more severe than it kind of should be.
Yeah. One time, this goes back a number of years, I had gotten bitten by a fly. I know.
A horse fly?
And I really got a good-sized bite, and it was a fly because I'd seen it on my arm, and I had knocked it off because I had felt it, and that got swollen. And then I went to the drugstore, and he had told me, what to use on it. But I was surprised that would happen from a fly bite.
Yeah. But that bite probably got maybe 1, 2, 3 days and then kind of started to go away.
Yeah, right. But it did swell up and it was itchy and uncomfortable and,
Sure.
that kind of thing,
So the brown recluse spider, that's a colorful name for it as well.
Uh-huh. Okay, thank you very much.
All right, thanks for listening.
I enjoyed listening to you and all the information that you give us.
All right, thank you very much.
So have a good day.
Thanks.
Bye-bye.
Okay, bye.
So spiders and ticks are arachnids. Technically not insects. Insects have 3 body parts and 6 legs. I love to say, this. And arachnids have 2 body parts and 8 legs, in case you were wondering. All right, so did we leave out anything with Lyme? But finally, I guess, when should you see a specialist? When would I send the patient to a specialist? Well, one, if the diagnosis is in question, it's always a good idea to get a consultation. Patients will sometimes say, well, why do I need to go? I said, well, I need this person to either agree with me or disagree with me. Either way, I need to know. As your doctor, I want to know. Look, sometimes there's a lot of literature out there, a lot of things on the line. People get very nervous. They read things. So sometimes I simply refer the patient just to hear it from another source that this is all, you're going to be fine and everything's okay.
For their well-being.
For the well-being. Something I briefly mentioned babesiosis, but unfortunately the wonderful insurance companies can be difficult with one of the standard medications that treat this called atovaquone. And there are times where I have not been successful getting it approved, which means the patient continues to have symptoms for another 3, 4, who knows how many days. And so sometimes I refer a patient with babesiosis just to help with that care. And if anyone needs an intravenous treatment, the Recephin we mentioned briefly as well, that would be reasons to go.
Yep.
All right, so we're going to move on from Lyme. I thought we would talk about some interesting local news, and this was in the news paper this morning, and I'm going to pull up the article right now. Should have done this during the break. Where's my producer? Let's see.
Well, can you say what it is?
Well, it's right there. Okay, so now it's frozen. So basically, we're having a new facility open in Kingston. Step One. Step One is a substance abuse center. They are primarily based out of Highland, but they have some satellite locations in Ellenville, for example, and they opened one in Kingston, over by Aaron Court, right by where I work. So let's see. It says Step One Kingston was officially launched as a privately owned behavioral health care center this summer with a grand opening celebration at Aaron Court. Step One Kingston, not unlike its Highland mothership, with branches in Ellenville and Lake Katrine, specializes in outpatient treatment of chemical dependency and alcohol abuse. So I think what else? They also have traumatic brain injury specialists on site there. There's counselors that are credentialed in alcoholism and substance abuse. There's licensed mental health counselors, social workers, and a psychiatrist who are able to treat the whole person. It's prepared to treat individuals whose lives are affected by dependence on alcohol, opioids, and everything in between. Anything that somebody is abusing to change their brain chemistry and is creating havoc in their lives, as well as co-occurring mental illness, can be tackled at Step One. So I thought that was excellent news. In addition to programs offered for adults, there are adolescent services for 15 to 18-year-olds. And I just thought that was an excellent community resource. I'm trying to find the phone number. I have referred a patient over there for counseling. So, when we feel like there's not adequate resources in our community, this is a good example of a new resource and an organization that really has a track record of providing excellent care and services. So
That's outpatient only, right? There's
yes, but that's kind of the one of the areas that can kind of break down. It's almost like models healthcare in a way. When something is really an emergency, you can kind of get the care. It's what happens next. So, for example, it happens a lot where someone gets admitted for detox. They then might wind up at an inpatient rehab for a couple weeks, and then they get discharged. And that segue is particularly when things can fall apart. And that segue is probably the most important of all. People then kind of go home. Well, what happens when they go home? Anybody in the substance abuse world will talk about triggers and things that can kind of start rekindling their addictive tendencies, seeing people in your neighborhood or just whatever. And that is really where the breakdown occurs a lot. It's unfortunately way too common for a patient of mine who's been in treatment like that to kind of call me panicked after being discharged from a facility, saying they need this, they need that, they need this, they need that. And I say, well, that's very unfortunate that this wasn't taken care of before you went home. So an organization like Step One is really well equipped to provide that service for people.
That's great.
It sounds like it can be over and above maybe what Health Alliance had.
Right. Well, Health Alliance had inpatient.
We had to create a cultural and social answer to that loss.
It still doesn't fix the problem of Health Alliance taking away the inpatient component, that's unfortunate. Kind of like some business decisions that are made without really looking at the big picture. How important it is for an organization to maintain some degree of goodwill in the community, for example, because that's kind of a related subject. It gets a little close to the politics that I always say we try to avoid. But I wanted to, this is our county executive, Pat Ryan. So I'm just reading from the Freeman, July 7th. Ulster County Executive Pat Ryan is calling on the State Department of Health to halt expansion and renovation work at the Health Alliance Hospital campus on Mary's Ave in Kingston until hospital officials withdraw their request to permanently eliminate inpatient mental health beds in Kingston. I mean, that really, I don't know, that's something. Basically our county executive is saying, stop this, that's going to help the community until you do this. I don't know where that stands, by the way. I don't know whether the state's listening or not. But it's unfortunate.
Yeah.
Well, I have a few other topics to discuss. One is something that also comes up a lot, and people might hear about it. One is sometimes I'm told there's blood in your urine. Okay, did we ever talk about this before?
Have we talked about urine before?
Or
UTIs or that kind of thing?
Or just the topic of blood in the urine.
Yeah, but we can revisit that.
Oh, we did already?
Well, not last week.
Can't remember when.
There we go. Well, it comes up a lot, because we check urine. By the way, the world of evidence-based medicine, we're kind of not supposed to just routinely check urine. But a lot of it's still kind of a component of a lot of wellness physicals. A lot of doctors and other providers choose to make it part of their practice. But the answer of finding things that now have to be worked up, whether or not that's something that has to be done, the official answer is no. Anyway, well, but
so when do you say? So you don't routinely test your urine. When do you do it? Just if you're symptomatic?
Yes. Plus, if you notice the urine, we kind of divide it into microscopic, which means the patient doesn't notice it, and gross hematuria, which means the patient does notice it. So if that kind of almost sounds like a no-brainer, but if you are urinating blood, it should be evaluated. We will check urine for other reasons.
Protein.
So particularly someone with diabetes, a urinalysis might be part of the routine care. Typically, we're also doing a specific test called microalbumin. But I usually order a full urinalysis as well. And someone has symptoms, UTIs, and if a patient comes in and they're having some urinary symptoms, pain or burning, and the urinalysis, in addition to showing evidence of infection, also shows some red blood cells, that kind of has to, I don't know, I like to see it through to resolution. Unfortunately, blood in the urine can be a sign of cancer, bladder cancer and kidney cancer, and that's kind of the major reason why it kind of can't be ignored. I should say that the most common cause of microscopic hematuria, so we're talking about the blood that's seen in the urine by me, as opposed to the blood that's seen in the urine by the patient. The most common cause is unknown in about, according to this article, 43 to 68%. I'll round these numbers up. So say 50% are unknown. So that's part of the reason why routine testing can kind of just open this door of excessive testing, because at the end of the workup, you don't find anything. Infection will cause about 15 to 20%. Men will have an enlarged prostate. That can cause about 10%. Kidney stones, people can have kidney or bladder stones that are without symptoms but can manifest as blood in the urine. Bladder cancer is about 2 to 4%. Kidney cancer is less than 1%. Prostate cancer is less than 1%. Problems at the level of the kidneys, people with, maybe effects of like high blood pressure, they might have a little blood in the urine as a result. But that's beyond the topic. I part of my concern when I have a patient in front of me with this is I need to make sure that this is not cancer, and I need to decide if it needs to be worked up or not. So some risk factors for urinary tract malignancy in patients with microscopic hematuria. Remember, we've already established that if you notice the blood, you should seek care and have it worked up, even if it's caused by an infection. I was amazed by this. Age older than 35. I thought it was going to be age older than 50 or something like that. Male, more than female. Smoking is a risk factor for bladder cancer. It's very interesting. Why would smoking, do that? Well, there's one of the many, many toxins caused by smoking is specifically toxic to the bladder. It finds its way down there from metabolism and then can bring about a malignant change. There's some other ones there. Just people with chronic symptoms that are not explained. People who have had radiation for whatever reason. People who have had exposure to carcinogens, particularly in the carpet business. There was... and dry cleaning business, there were some toxins that have since kind of found their way out of being used regularly, but they were found to be toxic to the bladder and potentially cause bladder cancer.
So when you go to your doctor and you give a urine specimen and they dip it, right? Isn't that what you call it?
They dip it, yep.
And when you dip it, are you able to see the presence of, if you can't see it? You know what I mean? It just looks like regular. Looks like your regular urine.
Right. And the dip is kind of like a dipstick. It will test for many, many things. Test for glucose and protein and white blood cells.
Glucose is sugar.
It will test for red blood cells. So that's your blood. And there's different degrees of how concerning it is.
Is any amount of blood normal?
Well, there's different quantifications. They say, if there's less than 3 per high-powered field, that's that way it's really diagnosed, per high-powered field. First thing I usually like to do if there's blood in the urine is I like to send it for microscopic analysis. Pathologists look at it under the microscope. By the way, that's the type of thing that old-fashioned doctors used to kind of just do themselves. Before the days of DIPS testing, a doctor would take your urine, a couple drops, look at it under a microscope, and see if there were red cells or white cells.
What's the difference between a urinalysis and a urine culture?
Okay, well, urinalysis is a test of things to see if they're in the urine, whereas the urine culture is specifically looking for an organism that might be in the urine. So if someone has a UTI, a urinary tract infection, not always, because it's actually not recommended for most cases of routine UTIs, but sometimes the urine will be sent out for culture afterwards. So, and that will come back in 2 to 3 days, maybe a little bit longer, it depends. Either confirm urinary symptoms, and sometimes you'll also get every now and then you get a resistant bacteria, so you have a person on an antibiotic that is not being effective. So, but for a routine UTI, a 40-year-old woman who has no risk factors, the urinalysis really just shows evidence of infection. You don't necessarily have to do the culture.
So what is exactly happening when you send out for a culture? Are they growing something?
Yeah, they have
How does that work?
They have these little culture plates that you take a little bit of the urine on and you kind of smear it, and then it grows. And then if something's growing, the pathology lab will look at it under the microscope and give a more specific diagnosis. E. coli is by far the most common cause of urinary tract infection.
So that grows?
It grows.
Like a mold?
You can think of it like that. I mean, mold is a fungus, basically, but it's the same idea, yeah.
Oh, okay. Pretty cool.
Yeah, I guess so. Unless it's you.
Right, unless it's you. But, in the office, most commonly, patients are calling for their results, and the urinalysis will be back, but the urine culture won't be. And, it's hard to be patient when you're symptomatic.
Right.
And you're not sure exactly how to go about treating it yet, right?
Yeah. Right. And I will not send a urine culture for a routine, uncomplicated urinary tract infection. I wouldn't say that 100% of the time, but because it's just an unnecessary step. By the way, the treatment of urinary tract infections in this era of trying to trim down the duration of antibiotics has really gotten much shorter. When I was in med school, I remember the doctors giving antibiotics for 10 days. Basically, most urinary tract infections can be treated for 3 to 5 days. There's 2 common medications that are used. There's a couple others too, but Bactrim is a sulfa drug that is specifically a guideline by the CDC for 1 tablet twice a day for 3 days. And another one that's used a lot is called macrobid or macrodantin or nitrofurantoin. See all these names, same thing. And this is a antibiotic that just has a role in the bladder. It's interesting. It has no role anywhere else in your body. You don't get macrobid for a cold, for an ear infection or something like that. But anyway, that's a very good medicine, very well tolerated, and you give that twice a day for 5 days.
So we had an interesting patient call the office not too long ago and insisting on medication to be prescribed without a urinalysis. Yeah. And, the doctor it actually took a long time for the doctor to convince the patient that, first of all, even though, isn't this common when patients call and they say, well, I know, this is the symptoms I always get, and this is what I always have, and this is it. But the doctor said, I can't just give you this antibiotic without knowing for sure what it is. If it's this, I have to give you a different antibiotic. If it's that, I have to give you. But it's a long explanation to try to explain to the patient that what you think you have might not be what it is. So we have to, do the testing.
Did you want to say something?
Nope.
Okay. That's such a big topic. By the way, Rob and I can get T-shirts. Medical Mondays. That's a big topic.
Oh, good. Let's do that. We need those T-shirts.
I mean, that type of interaction has, comes from somewhere. I think this model of being convenient, kind of with the computer, online. You and I were ahead of our time because we were talking about telemed before it became a common word. But if you read telemed websites, they'll say urinary tract infections. In the urgent care setting, it's very common for someone to come in thinking they have a UTI and have that urinalysis be completely normal, particularly women, because there's many gynecologic symptoms that can mimic a UTI. So I would say never. Again, there's benefits to an established doctor-patient relationship. If it's a patient of mine who it really is a recurrent problem, I may say, okay, or I may kind of negotiate saying, fine, we'll treat it, but I want you to come back in after it's treated. Because remember, we got to make sure there's not blood there. And I've seen that. I've seen patients, we're going to go to a break, but we'll finish this subject, after the break. Sound good? Mid-sentence.
Mid-sentence, okay. Just remember where you pick up on that. Thank you, Dr. Eric Stamberg and Robin Baker. Many, many, many thanks, and many thanks to you for listening. You're listening to Kingston Community Radio, WGHQ, AM 920 and 92.5 FM. It's 8 o'clock a.m. right now, and it's Monday, July 19th, 68 degrees now here in Uptown Kingston, and a little bit about the weather for the next 3 days. Today, cloudy skies, a little bit of drizzle early today, followed by partial clearing, and a stray shower or thunderstorm is possible, a high of 81. Tonight, partly cloudy with a low of 62. Tuesday, mainly sunny, a high of 88. And Tuesday night, partly cloudy with a stray roving shower or thunderstorm possible, a low of 65. And Wednesday, mostly cloudy with a 40% chance of thunderstorms with a high of 81 for Wednesday. Wednesday night, mostly clear skies and a low of 51. We'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Get ready to go with Central Hudson on an epic adventure at the Dutchess County Fair, August 24th through the 29th. Visit us at our main booth in Building C and say howdy to Zoltar the Fortune Teller, who will predict your energy future. Then pop over to Central Hudson's booth at K29 to score 10 LEDs plus a desk lamp for only $10. See you in Rhinebeck at booth C30 and K29. Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And you're listening to WGHQ. Thank you for being with us on Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. Last portion of Kingston Community Radio was brought to you by Central Hudson. And this upcoming portion of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs. Discover the difference of buying local. Sales ongoing at their website at herzogs.com. Our call-in line is 331-9255. 331-9255 is your number. And let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker. Let's see what birthdays we might have. Welcome back.
All right. I am very happy because we have a birthday today.
Yay!
So today's winner will be winning a famous cow pie courtesy of Boyce's Dairy Milk House. Do you have the address of Boyce's Dairy Milk House?
62 O'Neill Street.
62 O'Neill Street
there you go,
in
Robin.
Kingston.
Mm-hmm.
And today's winner is whom?
Jamie Anson from your friends at People's Place. We hope you enjoy your special day. So you just have to go by 62 O'Neill Street in Kingston, and I think you get to make the cow pie yourself.
Really? Who would
Well, you
do
don't
that?
make it yourself. You say what you want in it.
Customize it.
Customized.
Yes, customized.
Yep.
Oh, yeah.
Moo.
Congratulations, Jamie. Happy birthday. So, have you had a famous cow pie ever?
No. I certainly we've had stuff from Boyce's Dairy Milk House. I mean, it's quite.
And the
delicious.
ice cream cakes?
And I just like
Amazing.
I just like the setting on a summer eve, going over and getting a cone and sitting outside. And I tell this to people who got the sweet tooth. They say, don't buy the gallon or half gallon that's going to sit in your fridge and talk to you every time you walk by. You know, if you have that little hankering, then go buy, get a small cone or whatever, which, by the way, is still pretty big. And just go enjoy a summer evening and satisfy your sweet tooth that way.
And support Boyce's Dairy.
And support Boyce's Dairy.
Out where I live, we have a great ice cream place called Cherries, and everyone loves
Cherries.
it there too.
Cherry. Yeah, and there are a lot of good places, right?
Yeah.
But Boyce's is sponsoring the famous
Correct.
cow pie. Yes. Well, all right. So we were talking about kind of this dynamic of a patient kind of saying, I have this, I want this. It kind of goes back to the doctor-patient etiquette that we've talked about at other visits. You know, number one, don't start off the visit by telling me what you think you have. And number two, don't follow that up by telling me what you think you need. You know, tell me your symptoms. You know, and we'll take it from there. Okay, you know, make it analogous to what you tell your mechanic when you bring your car in.
Right. And then you can come to understanding, right? And
Right.
figure out together how to go ahead with treatment.
The reason, so you remember that whole industry of telemed, they really were kind of manipulating standards to kind of justify their existence. So if you read the fine print, they'll say the things that they can handle via telemed are routine UTIs in low-risk patients, you know, because they understand. I mean, I don't know how they define a low-risk patient. But, again, it's very common for someone to be wrong about what's wrong with them, you know, specifically urinary tract infections. Women more than men. Because, by the way, UTIs are just more common in women than men. And there's always that possibility of something more serious underneath. Even if you have an infection, say you have a bladder tumor, the bacteria, you could have that infection because of the bladder tumor. You know, the bladder tumor acts as kind of like a magnet for the bacteria. And so we could treat it, we get rid of the infection. Doesn't mean you don't need more workup. So that was the reason I wanted to bring it up, because first of all, I think patients are told that a lot. Second of all, you know, what should you do about it? The workup is usually done by a urologist, and I am in negotiations to have a urologist on the show. And it involves, you generally want to look at the upper part of the urinary tract and the lower part. So the upper part, the kidneys. And you get a good look at them. You can start with an ultrasound, but the test that really does a better job of making sure there's no tumors in the kidney is a CAT scan. And then you generally want to have a cystoscopy, which is kind of like a colonoscopy for the bladder. A urologist goes through the urethra and investigates the bladder, see what it looks like. And that's really how you diagnose bladder tumors. Bladder cancer, thankfully, is actually very treatable in early stages. So, you know, as a primary care doctor, I just see that as my role. You know, I had a teacher in medical school, in residency, one of my attending physicians say, your job is to protect the patient. So, and I've kind of, that's, you know, stuck in my mind. So, and I protect the patient from chronic problems that might affect them, like high blood pressure, acute problems like infections, make sure that they don't have something more serious underneath, such as cancer. And at the same time, I try to protect them from over-testing and over-treatment, which has its own kind of cost and negative impact. So it's a complicated job we got.
Yeah.
But blood in the urine kind of should be explained. Women can have it just for being kind of postmenopausal. It's usually a small amount, though. But I don't know. I have a very low threshold for referring someone with persistent blood in the urine over to a urologist for workup. And we do have several urologists in the community. There's Dr. Chazkel, who's been in the community for many years, and Dr. Stellato, and then there's also
Dr. Parker.
Premier Urology is over by Benedictine, former site of Benedictine, Mary Zav, and yes, that's Dr. Walter Parker, and oh gosh, some of them work out of their Poughkeepsie office, so I hope I'm not forgetting to mention anyone, but we do have sufficient urology in our community.
Yeah, those guys are good doctors.
Yes, but we'll give some kudos to the other guys too. They've been doing this a long time.
Yeah.
And it's okay to go see them as well. All right, let's see what else we got here. How about you ever have an earache?
Yes. Thankfully, not too much, and thankfully, I had children that were not susceptible to a lot of earaches. Only had a few, thank goodness.
Right.
So painful.
And the reason I'm bringing it up is there's one type of earache which shows up this time of year, commonly called swimmer's ear, but it's also called otitis externa. And I see a lot of cases of this, but I do kind of see it year round. But
is it really from swimming?
Well, it's kind of like saying tennis elbow. I mean, yes, it's from swimming. Yes, it's from tennis elbows from tennis, but it doesn't mean you have to be a swimmer to get swimmer's ear or a tennis player to get tennis elbow. The ear, you look at your ear, that's skin, and then as you go into the ear, that's called the ear canal. There's skin is there too. Well, in the summer months, things can get moist, particularly like if you go swimming, water can get in the ears. And at the same time, it's kind of hot and sweaty, and that skin can get irritated. And when it gets irritated, a couple things can happen. It could become painful. It can become itchy. It can get so severe that your canal is swollen and the hearing is muffled. The pain could be quite severe. So anyway, that's another example, by the way, of people.
So is it like a bacteria infection, or?
It is, but it isn't. It's a combination.
It is, but it isn't.
It is, but it is. It's a combination of factors. It's irritation of the skin, so it's kind of like a type of dermatitis. At the same time, things live in that ear canal, including some bacteria and some fungus. So the treatment for swimmer's ears
good bacteria and good fungus?
Not necessarily. That's usually more in the context of like your gut, where you have good bacteria. So this is like, look at my hand. I could have Staph aureus on my hand right now. As a matter of fact, I probably do. But Staph aureus, if it gets into the skin, and a break in skin, can cause a rather severe cellulitis. So it doesn't make it good or bad just because it's on my hand, but if it gets in there, it causes problems. Same thing with the bacteria that can kind of exist in your ear.
Okay.
All right.
Making me itch.
And it's also a good example of you get one more time where the patient is frequently wrong about what's wrong with them. Because they'll say, because sometimes maybe they have a little stuffy nose or whatever. They'll say they need an antibiotic, they have an ear infection. Most of the time, you don't treat this condition with an oral treatment. You treat it with a topical treatment.
So when you're looking in a patient's ear with your light, what are you looking for?
Well, the first thing I do, particularly if I'm working up ear pain, is I wiggle the ear. And if that reproduces pain, then that suggests an outer ear involvement. And you also press on this little thing right here. That's called the tragus. And that could reproduce pain. And then back here as well, that's called the mastoid. But when you look in the ear with the otoscope, you're looking at the canal, and you're trying to see all the way to the eardrum, which is also called the tympanic membrane. So the canal can be, first of all, you can have wax. We talked about wax, I think it was just last week. Boy, we're really on a little continuum here.
On an ear string.
And by the way, wax can kind of make it worse too, because if some of this moisture and heat and schmutz gets behind the wax, it also will increase the likelihood that you'll get an otitis externa. So these things are not necessarily separate. The canal will be the ear canal, which should kind of look like normal skin. It might be red. It might be the canal itself might be more narrow. You could have what's called an exudate, kind of like a whitish coating on it, and that's usually what you do to diagnose swimmer's ear.
Is that stuff ever like tested?
Nah, in resistant cases, there is something called malignant otitis externa, which is a much more severe case, and it's seen almost always in diabetics. But that's someone who needs usually admission for IV antibiotics. So the treatment for swimmer's ear is usually topical drops. And the most commonly prescribed is something called corticosporin drops. It has a little steroid in it that will help with the dermatitis. It has a little antifungal medicine in it to help with the fungus, a little antibiotic properties. So it's kind of a catch-all. There are some probably better products, but they're very expensive. Cipro. Cipro is an oral antibiotic that's not used as much anymore because of concern over problems with tendons, but it is available in a drop formulation to treat this, but it's very expensive, and so I usually don't prescribe it. And then the topic about keeping the ear dry, that's a tough one, particularly for your 10-year-old kid who wants to keep swimming in his summer months. You should try to keep the ear as dry as possible. If I tend to treat this for 10 days because it likes to come back. So you really want to do all 10 days. Sometimes,
do you use like ear plugs or?
Well, like for a kid who's swimming, that's complicated. And, it's the type of thing that hasn't really been studied. The idea is to keep moisture out, but at some point some moisture gets in, and now you got an earplug there to keep the moisture in. So maybe if a kid is prone to the ear, to really, maybe while he or she's swimming, but as soon as they get out, you really got to take those plugs out. I remember being at a pool or beach or whatever, and some kids running around with the plugs in all day long,
Yeah.
So I don't recommend that. It's interesting. I wonder if it happens so much with ocean water, because maybe there's some properties of the ocean water that, with the salt water, a little different. I don't know.
We'll have to research that for next time.
But it is interesting that we brought it up because it is, again, it's something that people can be wrong about. So this whole idea that you're going to treat stuff without a proper evaluation is really very flawed. And they can fool you too, and they can pull me down the wrong hallway sometimes. Doc, remember that thing I had last year? I think I got it again. And then the story starts. I really can't do that. I'm busy, but So your doctor you're working with, they really kind of just stick to their guns, is doing the right thing.
Right.
They
want to properly evaluate you and then properly treat you.
Right. It's amazing how the healthcare system is so committed to excellence. Remember, we joke about every hospital claiming they're number one, right? And then we say, if some hospital says they're number 6, I always say go there because at least they're telling the truth. They can't all be number one.
I'm first.
Yeah. We did our own study and we found out we're number one. But all of a sudden, the times where the healthcare system seems to be more than willing to settle for sub-quality care. And that's very confusing to me. The idea that telemedicine is okay.
Well,
all of a sudden.
I heard the phrase better than nothing.
Better than,
a lot.
That's a rationalization.
Right.
We're like, oh, well, yeah. And again, yes, we needed it over COVID. And it will be here to some degree to stay, but it's flawed. And any attempt to explain it otherwise is just not being upfront.
Right.
Better than nothing cannot be number one.
That's right. That's correct.
That's the slogan.
Yeah.
Telehealth America, we're better than nothing. It's interesting. All right. I guess I was going to talk a little bit about middle ear infections, but I wanted to bring up the external ear because I've seen my share of it, both in kids and adults. In adults who, you also see it a lot in people who, in this day and age, but a lot of kids or adults have headphones in all day. People for their jobs have to wear kind of, protective earwear, which they should be, by the way, but that can kind of also
Hold the moisture in.
Hold the moisture in, and yeah. So those are other settings where you can see this condition. And it can be kind of a gratifying condition to treat. The person can be, sometimes it's so swollen that you got to get the drops in there. So we use a piece of gauze called packing, and we kind of with a set of tweezers just kind of gently introduce it beyond that blockage. So then if you put the drops kind of along that gauze, it will
trickle
saturate and trickle in. Yeah, that's called a wick.
Sounds like a wick.
That's right. But by the way, that's also again there are over-counter products for earwax removal. But sometimes people will be doing that until they finally come see me, and I'll say because it's really the wrong treatment. That's why it's not working. All right.
So we were going to talk about the dreaded edema.
Edema. Well, the reason I wanted to bring up swelling is because this time of year, people are a little more swollen.
Because it's hot?
It's hot, yes. Yes, and it's very common for people to say they are swollen. Women, more than men, will feel swollen. Remember, there's also hormonal roles, so a woman will be a little swollen, a little fluid retention, usually right before their menstrual cycle, and then it will get better after the cycle. But this time of year, things are hot. When you're warm, your blood vessels will dilate and therefore get a little engorged, fluid will accumulate. So what do you think?
So besides hormonal, why else would you get swollen? It's an indication of something else that's going wrong?
Well, that's a good question. That's why it's a good topic to bring up. It starts with, an interview and examination of the patient. So the first thing I want to know, if someone has swelling, yes, some questions, how long has it been there? Is it getting worse? But I want to know what else they're feeling.
Where's the swelling develop? Are you just swollen all over, or what?
That's what's usually, we're going to focus on lower extremity edema. Sometimes it's called dependent edema because it's caused by keeping your legs down. We also see it in our society more because people are more sedentary. They can spend hours just sitting at a desk or whatever. So it's kind of a perfect storm there when you throw in the heat and the sedentary jobs and maybe some hormonal roles. It's pretty common for someone to have some swelling. I want to ask if there's other symptoms, particularly any respiratory symptoms. Are you feeling short of breath? Are you having any difficult time sleeping? Do you need to put some extra pillows under your head in order to get comfortable? And then I want to ask about cardiac symptoms. Are you having, obvious things, chest pain, palpitations? And the reason those questions are important is we're making sure that the swelling is not due to a cardiac cause, a heart-related cause. Sometimes the swelling is also seen in people with rather advanced lung disease like COPD, where the lungs are kind of backed up and therefore the right side of the heart is backed up, and then that can also permeate all the way down to the legs. Less commonly, it could be due to kidney problems. It's interesting when someone has a kidney condition called nephrotic syndrome, where they lose protein, they will get swelling. Protein is needed to keep fluid in the blood vessels. So if you're low protein, the fluid will seep out of the blood vessels into the surrounding areas. More ominous, but much less common, are something in the abdominal cavity that could be causing blockages, liver problems, cirrhosis, cancer, gynecologic problems as well. So it also comes back to taking care of someone's overall health as well. If a gynecology evaluation is necessary, that should be conducted. There are some medications that will increase the risk of swelling.
And this is swelling in your feet, ankles, and lower legs?
Pretty much, yeah. It's called dependent edema. So, for example, if we have someone like in the hospital who's bedridden, they may not have much swelling in their legs because their legs are not down. The swelling actually will accumulate in the small of their back. But this is we're the focus of the discussion is really on just kind of like someone who says my legs are swollen. Clotting is a possibility. DVTs, but it's unusual to have those in both legs, but it can happen. Just problems with your veins. People as time goes on, they can develop what in their legs? Varicose veins. They can either be kind of little small things like spider veins, or more large. You can kind of trace it throughout the bottom of the legs. Women have this more than men for hormonal reasons and also childbirth. But plenty of men have this as well. Particularly, sometimes I see it in like physical guys, because they're still kind of working those muscles all the time, but the veins are giving out. So that can cause swelling in the legs. You can also have something called lymphedema, and these things are not kind of separate. You can have both of these at the same time. Lymphedema has to do with the lymphatics. The lymph system is kind of like an alternative to your veins. Veins drain blood. The lymph system is kind of like another route, and these things can also get kind of damaged over the years, and then the lymph will accumulate. And that's called lymphedema, and that could be a challenge to treat. The best treatment for lymphedema is aggressive and consistent compression of your legs. There's a genetic component to lymphedema. It does. Some people can run in families, and it's complicated. It's a very frustrating condition to treat. I was looking for they had listed medication. Here we go. These are common medications associated with swelling or edema.
What do you mean? If you take these medications, it can cause one of the side effects?
Yeah.
Is swelling?
Yeah, the most common one, in my opinion, are these things called calcium channel blockers. The most commonly prescribed of that is amlodipine. A lot of people are on this medicine. By the way, it's otherwise a great medicine. Very few side effects. It does a good job of bringing blood pressure down, but it can cause swelling. Other blood pressure medications can also do it as well. Beta blockers, anything that ends with OL, metoprolol, propranolol, atenolol. Let's see. Hormonal treatments, anything can do it. Okay, women on contraceptives, or men on testosterone replacement, people on steroids, anti-inflammatory medications, NSAIDs, all have a fluid retention component. So ibuprofen, for example, can also do it as well. But in my experience, the most common medication linked to it is the calcium channel blocker, amlodipine. When you assess for edema, sometimes you have to kind of gently put your finger over your shin and press, and you kind of gentle pressure for like 30 seconds or so before you kind of appreciate a little divot. That's called pitting edema. All right, so what do we do if someone has edema? That's a picture of lymphedema.
Yeah.
Yeah, you can see how severe it could be. Well, sometimes the best treatment is nothing, to be honest with you. If there seems to be a medication causing it, an alternative should be sought. There are times I will prescribe a gentle diuretic, but that's not, that's may work, it may not. Remember, we have to get the fluid out of the legs into the heart, and out to the kidneys in order for the diuretic to work. Diuretics work on the level of the kidneys. So if the blood is just in your legs, all the diuretic in the world may not help too much because it's not getting to your kidneys. So that's why some sort of compression is important. People don't like to wear these, especially in summer months. Women like to wear sandals and these stockings can be hard to put on, especially for older people. So I understand, but that is the best treatment. You go to any vascular surgeon, that's what they probably say all day long. compression stockings. There are times that I prescribe like a low-dose hydrochlorothiazide, 25 milligrams, particularly if they have hypertension. If someone has high blood pressure, a diuretic, otherwise known as a P pill, is a good choice.
Yeah.
That's it?
Was there anything else? There's all these like ads that you see, like these foot massagers that like they put electrodes up into your legs, or there's like a ginger extract that if you rub ginger extract on your legs, it'll.
There are a lot of natural diuretics. I'm not convinced that I haven't heard ginger being one of them, and I'm not quite sure why rubbing something externally will help mobilize fluid that's inside. So I'm a little skeptical about that one. When people, for example, have lymphedema, they will get referred to a lymphedema clinic where they do kind of this therapy to try to push the lymph out. So there might be some products that kind of do that while you're watching TV at night with your legs down. Aha, that's another treatment, by the way. When you're home, get those legs up. All right, we're going to go to our last break of the morning.
Thank you, Robin Baker and Dr. Eric Stamberg. Thank you so much for bringing us around to 8:30, and we're at the bottom of the hour, and it's now 8:30. It's 66 degrees here in Uptown Kingston on this Monday, July 19th. You're listening to Kingston Community Radio, AM 920 and 92.5 FM. This last portion of Kingston Community Radio was brought to you by Herzog's, because the colors and quality of paint that you choose matters. Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints and including the eco-friendly Aura line. Color decorating consultants and expert interior designers are there, ready to assist you with your home. And visit Herzog's in the Kingston Plaza. Today, cloudy skies, little drizzle early, and I think that's followed by a partial clearing. A stray shower or thunderstorm is possible today with a high of 81. Tonight, partly cloudy with a low of 62. Tuesday, mainly sunny with a high of 88. Tuesday night, partly cloudy with a stray roving shower or thunderstorm possible on Tuesday night, a low of 65. And Wednesday, mostly cloudy with a 40% chance of thunderstorms on Wednesday with a high of 81. Wednesday night, mostly clear skies, a low of 51. And we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Kids dream big. Protect your child's dreams by keeping them healthy. If your son or daughter is age 11 or 12, the American Cancer Society recommends giving them the HPV vaccine to help prevent HPV cancers later. Learn more at cancer.org/dreambig.
Together with Susan G. Komen, we're committed to reducing U.S. breast cancer deaths by half.
We're going to do it by 2026.
Visit Komen.org/unacceptable.
Hey everyone, let's all stop what we're doing and take a moment. You see? Every moment can be kind of special. But they can be loud moments, goofy moments, dorky moments, it doesn't matter. Because every time dads like us take a moment like that to spend with our kids, well, it's pretty momentous. So let's take a moment to make a moment. Call 877-4DAD-411 or visit fatherhood.gov. Brought to you by the U.S. Department of Health and Human Services and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you and support KCR.
And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley and one near you. And your call-in number is 331-9255. That's your number. Call us in. And you're always welcome to call 7 to 9 a.m. every weekday here at KCR. Let's get back to the on-air studio with Robin Baker and Dr. Eric Stamberg. Welcome back.
All right, welcome back. Final half hour of this morning's show. We were talking about various topics. We spent some time talking about Lyme disease, and we spoke about blood in the urine. We spoke about swimmer's ear, and we were speaking of a very swell subject we were just talking about, edema. Yes. A swell subject, yes. Yeah, all right. Sometimes people with varicose veins, large veins, you can kind of see them. They can be uncomfortable, and they'll have them removed, but it really doesn't cure the edema. Remember, first of all, those veins aren't working, and you have alternative pathways, but obviously they're not working either. So taking out the vein itself might help the symptom of discomfort go away, but it's not going to help the swelling get better. That's just something to kind of remember.
So I thought maybe we could talk about preventative medicine.
Okay.
And what does that mean to primary care?
Okay. All right. Well, what does preventative medicine mean to you?
I think of it as getting medical care so that I don't get sick.
Right. Right. When we were in medical school, they taught us about prevention, and there's 3 types: primary, secondary, and tertiary. Primary is trying to prevent a disease before it ever occurs. Secondary is kind of trying to detect something early and before it has any effects or significant effects. And third is kind of like, it's here, let's just minimize its effect so we don't get further problems. So a good example of the third would be someone has diabetes. Now let's make sure they don't go blind. So let's make sure they see an eye doctor and get monitored for that.
Or lose a limb.
Right, or lose a limb, absolutely. And prevention is a cornerstone of what primary care medicine's all about.
When were you in medical school?
In the early 90s.
So this whole idea of like wellness is not new.
No, the idea of like a physical, you should see your doctor for a physical, I think kind of came about in the 50s and 60s, but what was the doctor doing? Doing a traditional history and physical, reviewing a long list of symptoms to see if you have any evidence that something might be wrong with you. Probably checking your blood pressure, listening to your heart, whatever, using the tools of the time. But a lot has happened since then. I mean, so prevention's kind of divided into categories. If you want to do primary prevention, it's kind of like healthy lifestyle. For example,
don't smoke.
Don't smoke. Eat a healthy diet.
Exercise.
It's a good one. Try to control stress in your life. To get enough sleep. Drink enough water. Limit your alcohol. That's all good examples of primary prevention. And secondary, when someone comes to see me for a wellness visit or a physical, whatever you want to call it, it's almost semantic, so who cares? Basic things that are being done, you're checking your blood pressure. Remember, high blood pressure is a silent condition. People don't really know they have high blood pressure.
They feel fine.
Yeah. But that needs to be identified and treated early to prevent complications of it, such as heart disease and stroke. So that's a good example of secondary prevention. Other screenings have kind of showed up during the past years. We run some basic labs. We screen people for early stages of diabetes. Remember, diabetes also has a long period of time where it doesn't cause symptoms. And cholesterol, I bet that kind of came about in the 80s. Get your cholesterol checked. We didn't really know what to do with the results, but we were, told to get our cholesterol checked. Back to primary prevention, we try to prevent certain types of infections. Flu shots, a good example. Pneumococcal or pneumonia vaccinations, shingles vaccines. So vaccines are a good example of trying to prevent infections. Cancer prevention, but you can't just do, like a kitchen sink approach, or a car wash. We don't put the whole body into car wash. It has to be
right. Everybody's not getting a PET scan.
Right. And so
you should be thankful that you're not getting a PET scan.
Right.
right?
And we're focusing on common cancers and cancers that we know if they're picked up early makes a difference. So for women, breast cancer, mammograms are kind of still the standard of diagnosis for that. An article I read recently showed no value of adding an ultrasound to that for most women. Some women choose to get thermography. We talked about that a couple months ago when Dr. Curcio was our guest, and she really recommended against that. Anyway, so mammograms are very important. A little bit of discussion about when to start and how often to have them done and when to stop. But generally, if your healthcare provider is recommending a mammogram, you should get it. And you probably should also have a breast exam with it, although I kind of feel like if I'll take the mammogram at least. For both men and women, colon cancer prevention, the age of routine screening was recently dropped from 50 to 45. That's prevention. Back to women, we got cervical cancer screening, the Pap smear, probably the first example of success at screening, women, to really cut back on the incidence. And now the cervical cancer kind of comes into the realm of primary prevention because the HPV vaccine is primarily to prevent cervical cancer. So it just shows you how these things overlap a little bit.
HPV also good for boys.
Boys as well, for a couple reasons. They can get cancer from it. And also, again, the big picture, if fewer boys have it, fewer girls will get it. So it's good to do as a citizen of this country and planet. Prostate cancer screening is still kind of debated. I do recommend it. I usually do it at age 50 and stop at age 75. One article says do it 55 to 70. It's only 15 years. We never quite proved that picking it up early makes a difference. But anecdotally, I've had men who have succumbed from it, and I feel like until it's really, really resolved one way or the other, I'm going to keep doing it. An interesting topic that's come up fairly recently is lung cancer screening. Because lung cancer is like other cancers. If it's picked up early, it's very treatable. And for years, doctors were improvising a little bit, doing an X-ray. X-ray is just not good enough, because if you can already see it on X-ray, it's probably already a little too big. So it turns out this certain type of CAT scan called a low-dose CAT scan is a way to screen people. You have to meet criteria, although the criteria are being adjusted downward. You have to be currently between 55 and 75. I read that might be increased to 50 to 80, so 10 more years of people. And you had to have a 30-pack year history of smoking. So basically 1 pack a day for 30 years. Well, that might be getting lowered to 20-pack years. But I have, I've been doing it over the past 2 years, and some success. A couple patients were diagnosed early, and I think of one patient who passed away from lung cancer. And if in that time that I just think in retrospect, he definitely would have benefited from the screening. So that's what prevention is. I mean, there's probably more to it than that, but it's a big part of what we do. And we've talked about this in the show before. It's kind of a myth. And it's hard not to get defensive that somehow we are not into preventing illness. It's kind of what we do, and we do a lot of it. And I talk to people about it all day long. But I am trying to follow guidelines. It came up last week with Lifeline screening. You know what that is? Lifeline screening likes to go to church parking lots. They charge about $150, so it's not a lot of money by modern standards. They do some tests, and they do. It's just that they're not really following guidelines, but they, people do it, and they, occasionally, they do find something, an aneurysm. Aneurysm screening is also part of the workup these days with certain criteria. But they're really not following guidelines. So I had a patient who had that done, and he came in for his checkup, and he brought the report. They found a mild early blockage in one of his carotids. We talked a couple of weeks ago how the United States Preventative Service Task Force came out firmly against screening people for carotid disease. But it was really mild what he had, and I said, okay, this boils down to what we're already doing, which is treating your risk factors. He didn't smoke, which was great. He could do better with keeping his weight down, but he's doing okay. Make sure his blood pressure is controlled. Most importantly, we get that cholesterol down. So we decided to use that data and adjust his cholesterol medications. But I a little wary of things in parking lots. I don't know. Little caution.
So reasons to go to the doctor. You don't feel well. Go see your doctor, right? But when you do feel well, this is the reason to go to your doctor.
Go once a year, even though you're right. You're 30 and you're healthy. In a way, we're not doing much, but you're still coming in to say hello. And I'm fine. Right. What's that?
Yeah, you're creating a file.
Right.
You're tracking the person's health and anything that can go up and go down and things like that.
And I find that even with younger people, I've kind of adopted a style of really focusing on their nutrition. Because as people get older, they put weight on. So we're trying to, get that message across to people when they're 30. I always say if you put on 3 pounds a year, when you're 30, you're going to be 30 pounds heavier by the time you're 40. So, trying to get them to understand that, now's the time to start making changes. And
so how busy is your office lately?
It's pretty busy. Yeah. I mean, unfortunately, I feel too many people are not keeping their appointments, which is very frustrating.
Right. We have a deterrent at our office. I don't know what your policy is, but, there's a no-show cancellation policy that, it's a 24-hour notice. If you have to cancel or reschedule your appointment, really all you're doing is being courteous. I mean, you can't make your appointment. Someone's blocked out time to see you, and someone else can be seen.
Yeah.
If you can't get there, it's okay. You can't get there. But that policy actually, if you get sick or your car breaks down, okay, you're not going to get charged a fee. But the truth is, if it happens over and over and over and over, they have grounds to just let you go as a patient. It's just a matter of being
take care of someone who doesn't show up.
Right, by being courteous. So, yeah.
And it's everyone has a cell phone. It's going to be easier to call and. In my new page, there's a wait for new patient appointments. And whenever I have someone not show up, I go, there's someone else who's waiting to be seen, so it's frustrating.
You think there's a shortage of primary care doctors here in our area?
Yes. I don't think it's as bad as it in other areas. And I think the main reason for that is the Family Health Institute running a residency program for 35 years or so. That a lot of the local docs are graduates of this program. So the residency program is completely, satisfied that part of its mission. So Ulster County is in better shape than other counties.
Don't you have a patient that travels for like an hour and a half away because there's no primary care where they are?
Some patients, who really show dedication and loyalty, and it's very much improved. I sometimes say there's no one out there. I have some of my Suboxone patients travel out from Delaware County. There are Suboxone doctors there, but they're not accepting insurance. So these doctors are charging, $150 each visit, and that's a lot of money.
Yeah.
So they rather drive out to see me where they gets covered under whatever copay they pay. No, there's definitely a shortage of primary care, and the gig has gotten more complicated. There's more to do. There's more people. Well, 1 minute. We're gonna quit at 8:50.
Oh, I'm sorry. I was working with the clock, and because our electricity went out, and I'm readjusting. So no, we have almost 10 minutes.
Some guy off to the side with a cane just had grab you by the
so
neck.
sorry.
No
cane, no cane.
Touch on COVID a little bit for the last couple of minutes, but but there's a shortage of many other types of doctors as well. We've talked about this before. The cognitive fields. Tremendous shortage of endocrinologists. We have this epidemic of diabetes and the tremendous impact that it's having on our healthcare system, our cost of care. That's just one example. And that's a healthcare system that incentivizes some things over others. So you get more of this and less of that, and that has to be remedied.
So I find that kids, right, have a pediatrician pediatrician up until what, they're 18,
Yeah.
right? So parents make sure their kids go to the doctor. And actually, these are like regulations by schools.
Right.
There has to be a physical. Would parents be giving their kid an annual physical if it wasn't required by school? I mean, I don't really know, because basically when they get on their own, they'd stop going to the doctor, like unless they're sick.
Right. You're right. And, in a way, I don't blame them. They're young and healthy. They frequently don't have insurance, which is part of the problem as well. But I think it's a good idea to have a primary care doctor and say hello once a year. Well, a woman also has to make sure she's up to date with her gynecologic health. And that is also something that affects young women. So there's a couple different reasons. So we have 5 more minutes left. And I think we should just review the COVID issues a little bit.
COVID.
The incidence of COVID is up in every state except for South Dakota and Wyoming. By the way, it's the whole time through, it's been very high in South Dakota. So, for a long time, I'd have to check the current numbers, but the highest case per capita rate was in the North and South Dakota. Weird, huh? 2 sparsely populated states. But I'm worried, that we're going to go backwards here. So it just underscores the plea that I make towards patients to get vaccinated if you have not been vaccinated. Whatever reason you're kind of conjuring up in your head to justify not getting vaccinated, I'm just going to say unequivocally, you are wrong. You are wrong. You are not following logic. You're not following science. You're not following information. It's hard for me not to take it personally because I'm your doctor. You're not listening to me. Why are you even here in my office in a way if you're not listening to me? But I try not to make it personal. I try to just reason with people. Some people will come around. They just kind of need a little nudge. I think that number of people getting lower and lower. Other people are just really dug in with some misinformation, which is very, very frustrating. And they saw the governor of Florida, came out with some T-shirt saying, "Don't Fauci my Florida." I mean, what is he trying to say? By the way, Florida has pretty much the highest rate of new cases in the country right now. So what is he trying to do? What is that? Don't Fauci my Florida. First of all, it doesn't even make sense as a phrase. But why are you targeting Dr. Fauci? Why are you not coming up with a T-shirt saying, "I'm your governor and I want you to get vaccinated"? That's a good T-shirt. I'd buy that one.
I'd prefer you didn't pass away.
Yeah. Please don't die, governor. That would be a much better T-shirt. So we have to really don't Fauci my Florida.
Silly.
Am I missing some pun in there? Does he?
We have the...
No, just like you said, he's wrong.
He's wrong.
He's wrong.
We have the vaccine at our office. We're offering it to anybody. It doesn't have to be a patient there. They're offering it most of the day, every single day.
Yeah.
You do have to have an appointment. You have to be monitored for 15 minutes. We have the Moderna and the J&J vaccine at our office. 845-338-7140 is the office number if you'd like to call and be vaccinated. My son was given the first Pfizer vaccine at college, and then they do a lot of random testing at college. It's just all the time. So he was due to get his second vaccine 2 days later, but he tested positive and then had to quarantine for 10 days. So he was unable to get his second vaccine. And then, of course, came home and the summer started. And I called Ulster County, and they're doing the vaccines at Best Buy. They're having clinics all the time. They're walk-in. You don't need an appointment. And he was able to get his second vaccine just by walking in at Best Buy, so where they had the Pfizer vaccine. So they're there. They're ready.
Yeah.
It's easy to do and available.
It was in the news last week that 6 of the Yankees tested positive and they had to cancel a game, but 3 of them were vaccinated. The other 3 were not. So again, people walk away saying, "Well, look at that. The vaccine doesn't even work. They got it anyway." If everyone was vaccinated, no one would have gotten it. They're missing. They're walking away from this with the wrong message.
You know,
And also, right, there are vaccinated people who are coming down with the COVID virus, but they're not being hospitalized and they're not dying.
almost every serious case is in unvaccinated people. You know, it's a big country. Yes, you could probably find somebody or some cases that were quite serious. You know, even fatalities in someone who had been fully vaccinated. But those are very, very small percentages. So we just got to get over this. This is not good. You know, this is at this point this is self-inflicted. Anyway, so don't Fauci my New York. No, wait. Fauci or well, I don't want to be on the Fauci. I don't want to put him on a pedestal. I feel people are either they kind of worship him or they despise him. I mean, he's just a scientist, just a doctor. He's doing his job. I wish I think he's been a little wishy-washy sometimes, a little professorial. Well, we could do. When he should just come right out and say, this is what needs to be done.
This is what science says.
Right. Instead, he's trying to kind of negotiate and then come around and reason with people, and it doesn't really work. And sometimes I learned that over the years because there's different styles of doctoring. You could be like an old-fashioned paternalistic doctor. You do as I say, I'll see you back in 6 months. Where you try to say, well, these are our options. There are times where patients look at me and say, you're the doctor, you tell me what to do. And I say, okay. I like that. I'm telling you what to do. We're not talking about it anymore. Just do this. And, so different approaches to different patients.
Yep.
So our next show is in August. We do have a guest for August 2nd. We are having Dr. Brian Benetti, who's a bariatric surgeon, and also a nurse practitioner named Jennifer Scheffler. I think that's her first name. She specializes in medical weight loss. And that's a very interesting, growing topic. Some of these new products are now approved for weight loss. They tend to be also for diabetes, but there's some options out there. And already, again, she and I talked about it. The wonderful insurance industry is throwing up barriers to getting people on approved treatment. But, Obamacare, whatever you want to call it, kind of mandated that if something is FDA approved, the insurance has to cover it. That being said, doesn't mean they don't make it difficult, So that's part of the problem. And, I guess that's it for a week. We kind of kept the conversation going, didn't we?
Yeah. I think everybody can kind of benefit from like a show that's about nutrition and
sure.
Right. I mean, not everybody has a lot of weight to lose and not everyone is a diabetic, but everyone, is eating and, and nutrition's important. So I think that'll be really great.
All right. What do you say, Dan?
If we've rounded the bend, I'll take it back to
the smooth
Magic 92.5,
yes.
and we'll do fine.
All right, well, everyone.
What? Been a great day. Been a great day.
Go ahead, you do.
Thank the Maxwell family.
Yes, we always want to thank the Maxwell family.
Thank Dan.
Thank Dan.
Thank you.
Thank you.
And thank you.
Thank you very much.
Gracious crowd here. And thank you for listening. And stay safe. And if you haven't had your COVID vaccine or people who have not, work on them. Remember, we talked about families.
That's what I had.
Kids are saying, Mom, you're not coming to see your grandkids until you get that vaccine.
I had a mom come in this past week, and her kid said, you can't come over anymore. So she went and got her vaccine.
Yep. If that's what it takes.
She did just fine.
All right. So we'll see you in 2 weeks. All right.
Thank you, Robin Baker and Dr. Eric Stamberg. This has been Medical Monday, this Monday, July 19th, and 68 degrees right now here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley and one near you. Thank you for sharing the morning with us and participating in Kingston Community Radio, Medical Monday. And you are on AM 920 or 92.5 FM, or you're streaming online at mykcr.org. For all of that, we thank you. And this has been Inspired Discussions of, by, and for the community. We invite you to be with us tomorrow morning at 7 a.m. for a terrific Tuesday, and until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.
Good to me. What I can't feel, I surely cannot see. What can't you be? Good to me. And if it's not real, I do not wish to see. Why don't you be? Good to me. Why can't 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 you be? Good to me. Be good. Good to me. Be good to me. 'Cause I don't have a use for what you loosely call the truth. And I don't have the time for your overloaded lies. So you better be good to me. Yeah, you better be good. Better be good to me. Better be good. 'Cause I don't have the time for your overloaded lies. And I don't have no use for what you loosely call the truth. And you better be good to me. Be good to me. Be good. Be good to me. 'Cause I don't have no use for what you loosely call the truth. And I don't have the time for your overloaded lies. You better be good to me. Good to me. Better be good to me. Be good.
This is the Hudson Valley Station for great songs and magic memories. 920 WGHQ AM.